Healthcare informatics begins with documentation. Documentation is a nursing action that produces a written account of patient data, decisions that are made by nurses and others, interventions that are performed by nurses and others, and patient responses in the healthcare record. Documentation must be accurate, it must be comprehensive. Effective documentation helps ensure that care remains consistent, so that's called continuity of care. You can pass it along to somebody else and they'll do the same stuff because they see the same thing in the documentation that you saw or that you entered. Effective documentation saves time, and most importantly, it decreases the risk of errors. If you document accurately, nobody is making a decision based on inaccurate information. Does that make sense? Quality of care, standards of nursing practice, reimbursement, legal guidelines, all of this jumbled up together makes documentation and healthcare reporting an extremely important nursing responsibility. I really hope in your other classes you're learning about subjective versus objective data. My background is healthcare leadership. For over 20 years, I functioned in healthcare leadership, managing large nursing departments and managing reimbursement support from a very large Blue Cross Blue Shield organization. If it's not documented, it's not paid for. If it's not documented well, you assume that it is not done. You really do. If you don't assume, oh, I know they did that, but they didn't document, so, oh well, we're just going to assume it's done. That doesn't happen. It has to be documented, and it has to be documented in a very professional way. That brings us to subjective data versus objective data. So we don't use things like status unchanged or patient stable and in no distress. We don't use that kind of stuff. How do we know they're not in distress? I mean, that's just kind of silly to write that. We write appropriate objective data, test lab results, assessment findings, vital signs. What does their affect, which is facial expression, look like? Does their affect appear solemn? Does their affect appear? So that's an assessment. What are their vital signs? What is their medical history? What do we see? Is their face flushed? Are they frowning? Are they cringing? Are they shaking? That's objective, and that's perfectly appropriate and the type of data we should be documenting. Subjective data, on the other hand, is a judgment. It's an assumption. They appear happy. They seem sad. You can write that they're tearful. That tells you all you need to know. They're tearful. That either tells me they appear sad or they're in so much pain they're crying. So do you see objective versus subjective? Now there is appropriate subjective data to write, and that is what the patient tells you. When they say, I'm in pain, or when they say, I broke my arm because I fell, or I broke my arm because my spouse pushed me down the stairs, that is appropriate subjective. We can't prove that any of that is true, but the patient tells us, and we have to believe them. So quoting what the patient says is subjective, and it is the only appropriate subjective data that should be documented. The purpose of the medical record, so when you document all of this subjective and objective data, the purpose of it is for all of these things on the slide. Discharge planning should be started on admission. So you need to know why they're in the situation that they're in. So the data entered in the medical record facilitates interdisciplinary communication. It provides a legal record. It justifies billing and reimbursement. It allows for auditing, monitoring, and evaluation of care. Accurate documentation is the best legal defense for anything associated with nursing care. Mistakes result in failing to record pertinent data, that causes maybe failing to report an allergy, and then they get the drug and they go into anaphylactic shock. Failing to record your nursing actions, failing to record medication administration, failing to record drug reactions or changes in patient condition. Anything that you don't record or that you record inaccurately is potential to cause damage and harm to the patient. We don't want that, so we want to be accurate. When I used to take students. When I used to take students to clinical, the students would go do a very thorough assessment, and then they would come back and compare their assessment to what was in the chart, and they would find errors. Every day they would find errors in charting because the previous nurse just copied the assessment from the previous nurse, who copied the assessment from the previous nurse. And our students were shocked. And it was because they were entering from scratch their assessment data. And I don't want to say every nurse copies and copies and copies, but I'm saying that's an error. That's an example of an error. So the shift to electronic documentation occurred primarily in around 2010, 2011. So there was a Health Information Technology for Economic and Clinical Health Act, and it was a major driver in the adoption of using electronic health records across the country. So Medicare, which is run by CMS, and Medicaid had a electronic health record incentive program that helped give reimbursement to entities to allow them to afford electronic medical records, because to put one of these systems in place, it's very expensive. During that time, many single practice doctors had to join large groups because they couldn't afford to buy an electronic medical record for their practice. So a lot of the little mom and pop physician operations shut down, or they became employed physicians in hospitals. So anyway, since 2011, since this act came into place, electronic health records were basically mandated. And stage one was just focused on capturing patient data so that providers could share that data with patients, and if they maybe sent a patient to a specialist, they could easily share that data with other healthcare professionals. So that was the first stage of this transition. Stage two helped to have patients be able to go into online portals and see all of their healthcare information. So it was patient engagement through secure online access to their information. Stage three expands all of this data to help improve healthcare outcomes, and this began in around 2016. So all of this data that's in electronic healthcare records all over the country is being used to recommend changes in healthcare to improve healthcare outcomes of patients. So they're collecting all of this data. So as of now, there's evidence that electronic health records is effective in improving healthcare quality, but it's just effective. It's not proven that it's been effective. And that's because of the lack of personalization. So you guys are going to go into clinical and you're going to see a lot of drop-down boxes where they click. There's no more narrative. There's not a lot of it anyway. There's no more narrative that is really individual to the patient. There's check the box, check this box, check that box. And patient records look like, Mr. Smith's record might look like Mr. Jones's record if they came in for pneumonia. And that's why it's not conclusive that the switch to electronic health records is as effective as they wanted it to be. But our hope is that we'll continue working on it, and it will be. So an electronic health record is the digital version of patient data that was found in the traditional patient record. The term electronic health record is the lifetime record of all healthcare encounters for an individual patient in a healthcare system. So if my record at Inova is an electronic health record, my whole history going to Inova, and then I go across the country to Las Vegas Medical System, I'll have a new health record there because they don't share information. Does that make sense? So I'll have two electronic health records, one at this system and one at that system. Now, there's an electronic medical record, which is something different. It's a single patient encounter, and a lot of people get those confused. They say EHR and EMR. I'm going to look in the EMR. An EMR is just one encounter. It's when the patient came in, it's the consult record. It's one thing, and it's confused a lot. So an EHR is comprised of many, many, many EMRs. I hope that makes sense. So to meet agreed on standards for electronic health records, they have to have the following attributes. They have to provide a lifetime of patient records by linking all the data. So you can look at somebody's, let's use Fauquier Health. You can look at somebody's Fauquier Health current admission, and then you can stay in that electronic health record and look to see what they were admitted for the last time and the last time and the last time. An electronic health record must have a problem list with all of the problems for each encounter. The electronic health record must provide a method for documentation. So you have to document rationale, not just what you did, but rationale, so that clinical decisions can be tracked by everybody who accesses the record. An electronic health record must meet the standard of confidentiality, privacy, and audit trail, so it must be HIPAA compliant. Continuous access to authorized users must be available at any time. So it can't just be one person at a time can go in there. If I'm the nurse working in the patient record, the doctor on the other side of the building or from his home tablet can also go in and look at that patient information. And an EHR has a standard to have supportive links to accurate references and resource material. And an example would be a current medical drug reference, so that when you're in the medication administration record, you could look up what that drug is. In the old days, we'd have to carry a drug book reference book around. And then before EHRs had to meet this standard, we had computers, we didn't have to carry our drug book, we had to have a separate program that had current online medical reference. But now it has to be embedded, so it's kind of cool. They're trying to make it easier for the user. So an EHR also has to have direct entry of patient data. So there's all kinds of stuff. And everything with an EHR is focused on facilitating interprofessional communication, meeting professional, regulatory, and legal requirements, and improving the quality of healthcare. And regardless of whether documentation is entered electronically or on paper, the information needs to be, as previously mentioned, accurate, timely, concise, effective, organized, comprehensive, all that stuff. Confidentiality is vital with electronic health records. Only members of the healthcare team have access to the electronic health record. Patients still have to formally request copies of their medical record in order to read the information. So even if they go into an online portal to look up their information, they're given a special password or a special code. They have to enter special information so that the people who manage that information know that they are who they say they are. When you review your patient's medical records on the electronic health record, it must be need to know only. So it is unethical to view medical records of other patients. It is unethical to view medical records of your family member or yourself outside of the normal route. So if you work at a hospital and you have a procedure done at that hospital, you can't just sign on and look at your record. You have to follow the patient portal route to request copies of your own record. Does that make sense? So you can review your record, you just have to do it as a patient. You can't do it just because you have access as an employee. And that's the same goes with your family, the same goes with your neighbor. No one can ask you to look at somebody else's record. It's unethical. So when you print information from your electronic health record, you have to make sure there's physical security. So you're not printing it to a public printer. You have to make sure that there are appropriate firewalls. If you're in a hallway on a computer, you have to make sure that there's a filter screen or other special protection because you don't want people walking behind you and looking at that information. And when we print something on the medical unit from the electronic health record, let's say we print some patient data to use for our SIM charts. We might print the labs. If we print the labs for a patient, we're going to cut off everything that links those labs to that patient. So we're going to cut the name off, the medical record number off, the date of birth, everything that comes on that lab sheet. And then we have labs that you can't link to a patient. We might print a picture of an x-ray. We have to cut the same stuff off. So that's called de-identifying the information. Oops, I switched slides before. So this was the slide that says de-identify all the data. And there are standards for documentation in the electronic record that we have to comply with. So the organization has standards, and there is the National Committee for Quality Assurance and the Joint Commission that has standards for documentation and maintenance of electronic health records. The electronic health record should include everything listed here, absolutely everything. The purpose of clinical information systems are quicker orders. No need for a secretary to transcribe. We know what transcribe is, right? It is maybe the doctor hand wrote something and a secretary copies what they hand wrote into the computer. It might be a medication or it might be an order for a procedure. There were lots of transcription errors because doctors don't write well at all. And we were guessing. In the old days, we'd walk around with what they wrote on the paper chart, and we'd go, do you know what he said? Can you read his writing? Can you do this? And we would do everything possible to try to figure out what they wrote and guess what would be appropriate before calling them saying, we can't read your writing, Dr. Smith. So there's something called Computerized Provider Order Entry, CPOE. So that's part of an electronic health record. They're allowed to type in orders, CPOE. And then there are clinical decision support systems that help you make clinical decisions. So you could enter the patient diagnosis and it might help you, it might populate some tests that you might want to choose, or it might, you may enter the type of germ that showed up on the wound culture, and it may populate potential antibiotics that you may want to choose. So there's lots of decision support. When you're documenting an electronic health record, these are the guidelines. So the record-keeping forms found in electronic health records could be all of the above, everything listed here. So when the patient comes in, the admission form, there are all kinds of different flow sheets depending on which electronic health record you use. You could find the summary component, and that gives you a quick what's been done so far. Definitely, there's always care plans. This is why you have to learn care plans. The reason patients are in the hospital are because of care plans. Many times you're going to hear acuity rating systems help, especially to calculate nurse-to-patient ratios. So if you're EHR pulls data that you've documented on your patient to rate the acuity or the degree of illness the patients on your unit are, you want to make sure that your data is accurate and you've entered everything. Otherwise, this acuity data is going to show that you have patients that are not as sick as you think they are and they don't require that much care, and it can affect your nurse-patient ratios. But this is a whole nother course, and it's almost like a master's level course. My message to you is make sure your documentation in your electronic health record is accurate, because if you don't document everything, the people who oversee your unit won't think that you're performing or you're working as hard as you are. You're not as busy because your patients on paper, on the electronic medical record, don't appear as sick. Now, there's different documentation for long-term care and home health. Different guidelines for that type of documentation, and they don't have to use electronic health records. It has not rolled out to them. But you will see home health and long-term care facilities that are linked to hospital entities that have the same kind of documentation. It's important that you know how to record, interpret, and report data in order to critically think and apply all of that knowledge when providing patient care. There are specific fields of nursing called informatic nursing, and these nurses have advanced preparation in information management. They demonstrate proficiency with informatics so that they can support all areas of nursing practice. They can help you do 2 keystrokes instead of the 20 keystrokes to enter a nursing diagnosis. They can help do quality improvement research, and they can help design a system that flows with how the nurse actually does their work. So nursing informaticists, it's a growing field because of the significant improvements in electronic health records. The nursing process design is very traditional. It organizes documentation in formats like admission, post-op assessment, care plan, intervention lists, nursing notes, or discharge planning instructions. So it just helps outline scheduled activities and organizes it. Then there's the protocol or critical pathway of the way nursing information is organized in an electronic health record. And that type of pathway helps to say, you know, if I'm doing this on hour 1 of surgery post-op, then they're going to get better faster. I don't know if that makes sense, but the protocol or critical pathway design facilitates management of information using evidence-based protocols, also called critical pathways, to document care. So you can use a clinical pathway or a protocol, and it'll dictate what you're supposed to do based on evidence that shows if this is done, the patient will get better. So you have to know how your electronic health record information is organized to help you do your work. And that's it.